Welcome to our session on emerging treatments for advanced medullary thyroid cancer. I'd like to introduce Dr. Sarah Hamidi. Dr. Hamidi, along with having a really awesome first name, is a board-certified endocrinologist, currently completing a 2-year Oncologic Endocrine Fellowship at MD Anderson Cancer Center in Houston, Texas. Her main interests are advanced differentiated thyroid cancers and anaplastic thyroid cancer. Under the mentorship of Dr. Maria Cabanillas, she's participating in various research projects with the aim to improve treatment and outcomes of this rare yet aggressive disease.
Thank you so much for this introduction. And this was my introduction for the other talk I was giving about ATCs and DTCs, but obviously I see a lot of MTCs as well, and I work closely with Dr. Who. So hopefully this is going to be a session where you guys will learn some stuff about the future treatments and trials that are ongoing in advanced medullary thyroid cancers. So I'm very happy to be here, and hopefully, this is going to be a good ending of your day. So, oops. Okay, so I have nothing to disclose. And so over the next hour, what we're going to do is go over the currently available treatments for MTC and discuss the limitations of these treatments, and then talk about what are the emerging treatments that are being studied to overcome some of these limitations of the currently available treatments, and talk about ongoing trials in MTC as well. So as most of you probably know, about 1/4 of MTCs are hereditary, so inherited from the parent due to a germline RET mutation. And so these form part of the MEN syndrome. We have MEN2A, which is the most frequent, and about 5% of the MEN2 are MEN2Bs. And then the 75% remaining of MTCs are sporadic, so non-hereditary. It's due to a mutation that's in the tumor itself, not something that we inherited. And about half of these sporadic MTCs are also due to a RET mutation, and about 40% of those that don't have a RET mutation harbor a RAS mutation. There are different kinds of RAS mutations. Most frequent in MTC is HRAS, but we also have KRAS and NRAS mutations. So when we talk about all of these mutations, how do they cause medullary thyroid cancer? So they're involved in different parts of these signaling pathways, which we call the MAP kinase and PI3 kinase pathways. And actually, these are pathways that are just going to send signals to stimulate proliferation and survival of cells. And so when the cell is functioning normally, these signals just lead to normal cell growth and survival. But if we have any derangement in these pathways that lead to overactivation at any level, then the growth and the survival is going to be enhanced, and this is going to lead to cancer. So either we have a RET mutation that sends excessive signal and then excessive proliferation and growth, or we have the RAS mutation, like we mentioned, and same thing, the MAP kinase pathway is overactivated, and this leads to cancer. So let's talk first about RET mutated MTCs. So the RET gene can be mutated. We have different kinds of RET mutations, and there are multiple different mutations. In the hereditary MTCs, most frequent mutations that we find, C634 in the MEN2A, and then almost all MEN2Bs are caused by an M918T mutation. And then in the sporadic MTCs, most frequent mutation is also the M918T, but we have various other mutations that are possible. And so what we currently have for RET mutated MTCs, we have the anti-angiogenic drugs, so vandetanib and cabozantinib, and then we have the more selective RET inhibitors, which are selpercatinib and pralsetinib. And what these drugs are going to do is block either the RET receptor or here other receptors at the cell that also signal through the MAP kinase pathway, and they're going to dampen this excessive activation that we saw happens in medullary thyroid cancer. So the multi-kinase inhibitors, actually what they do is that they're going to act on the blood supply of the tumor. Why do we target tumors' blood supply? It's because when tumors get too big, for them to survive, they need more nutrients, more oxygen, and this is brought to them by the blood. And so to get more blood, what they do is that they're making this protein or signal that's called VEGF that's going to help them increase their blood supply. So VEGF is going to go bind to its receptor, the VEGF receptor, and then this is going to increase the blood vessels and ultimately allow the tumor to grow and survive. And so with the multi-kinase inhibitors, what we're doing is that we're blocking the VEGF receptor right here. And so we're not allowing the cancer cells to make more VEGF. And so we're cutting off its blood supply. And we're also stopping it from growing and proliferating. And then the selective RET inhibitors, what they do is that they're going to be more selectively blocking the RET receptor itself, and also so stopping the signaling. So before we go any further, now that we talked about how medullary thyroid cancer is caused, and what the treatments that we have are, how do we evaluate these treatments, either the ones that are already available or ones that are in trial? How do we know if they're effective or not? So there are a few things that we look at. There are the RECIST criteria that we use to measure tumor shrinkage on a treatment. So what is RECIST? It's just this language that all doctors want to commonly share so that we're making sure we're talking the same thing. And so what we do is that we pick a few tumor spots, we measure those before we start the treatment. Usually it's up to 5 different spots. We add all of these measurements up, and so we have our baseline measurements. And then when the patient is on treatment, every time we get new scans, we remeasure these same spots and we see, have they shrunk, have they grown, or have they stayed stable. If we have 30% or more shrinkage, we talk about a partial response. If all of the spots have disappeared, then it's a complete response. And if, on the contrary, unfortunately, the treatment is not working and things are growing, if we have a 20% growth or more, it's progressive disease. And if it's anywhere in between the progressive disease and partial response, we talk about stable disease. And often trials are going to report an overall response rate. So that's a response rate percentage. And usually, and what overall response rate means, it's the complete plus the partial responses. So it helps us assess how effective this treatment is. And the tumor measurements are often reported on what we call a waterfall plot. So every little button is a patient, and this is the change in the tumor size. So if it's going up, then the tumor is growing. If it's going down, then it's shrinking. If it's reduced more than 30%, we talk about a partial response. And if it has increased more than 20%, this is progressive disease. And then the other thing we look at is survival. So how are these drugs affecting survival? So we look at 2 things. We look at overall survival and progression-free survival. So overall survival goes from the beginning of treatment to whenever the patient passes away, or last time that we see this patient alive. And it doesn't necessarily need to be all of this time on the same treatment. We can get additional treatments, but as long as the patient is alive since getting that drug that we're looking at, this is overall survival. And then progression-free survival is the time between the treatment start and whenever disease progresses, or the last time we saw the patient and he continued to have a good response. And these survival outcomes are reported on these plots that we call survival plots. And so here you see either survival probability or progression-free probability, and here is time. And usually what we're going to look at is the median survival or median progression-free survival. So that means how much time does it take for half of patients to be either dead or have progressed. And the furthest in time this median is, the better the treatment is, and the higher up the curve is, the better the treatment is. So in this example, the blue curve is significantly better than the green curve. So now that we've talked about that, if we apply it to vandetanib and cabozantinib, which are 2 anti-angiogenic drugs approved for MTC, these drugs were approved following these 2 trials that showed that both of them improved significantly the progression-free survival compared to placebo. So placebo for vandetanib is in blue, vandetanib is in yellow, and we see that the yellow curve is higher up. And here the colors are inverted, so cabozantinib is blue, and it's also better than placebo. And so this led to the FDA approval of these drugs in 2011 and 2012. Multi-kinase inhibitors work. They're not great, and they have a lot of setbacks. So this is why, even though we had these 2 trials and these 2 drugs that were approved back in 2011, 2012, we continued to look for better treatments. Some of their setbacks is first, although they improve progression-free survival, they have not shown improved survival, overall survival, so they don't prolong life. And for example, this is for cabozantinib compared to placebo, overall survival is pretty much the same. Then none of these drugs offer cure. Once we decide to start one of these drugs, you have to stay on them long-term, right? So we can't stop them at some point and say you're cured from MTC. They're just controlling the disease. They also have multiple side effects. If you've been on these drugs, you know how toxic they are. And so they have a lot of side effects. And if we can find something better, then we definitely would love that. And then eventually, although they initially work, they're going to stop working at some point in most patients because the tumor develops resistance mechanism. So it becomes resistant to these treatments. So after multi-kinase inhibitors, we continued looking for better treatments for RET mutated medullary thyroid cancers. And just to talk about resistance mechanisms, so how does the tumor become resistant to multi-kinase inhibitors? So we're talking here about RET mutated MTC, right? So the tumor already has a RET mutation, and this is kind of being blocked by the vandetanib or the cabozantinib, but the tumor is smart and is able to develop additional mutations that allow it to overcome the blockage by vandetanib and cabozantinib and grow despite these tumors. And how does that happen? So one of the classic resistance mutations that we see on vandetanib cabozantinib is what we call a gatekeeper mutation. So the 804 gatekeeper mutation, and you might have heard about this mutation. And what it actually does is that it's going to impair the drug from going and blocking the receptor. So here's what we call the catalytic cleft of the RET receptor. So basically, this is where the ATP, the energy, is going to go in to activate the receptor. And how the multi-kinase inhibitors work is that they're going to come here, bind to the receptor, and impair the ATP binding so the receptor cannot be activated anymore. But when we have a gatekeeper mutation here, so the gate becomes closed, the multi-kinase inhibitor cannot go in anymore, and so the receptor continues to work. And to overcome this, what they did is they tried to develop drugs that are going to bind to the receptor in different ways. And that's where the selective RET inhibitors came from. So selective RET inhibitors, salpercatinib and pralsetinib, what they do is that they bind to the receptor by hugging it that way. So they don't use the gate, and so they can still inhibit it, although we have this gatekeeper mutation. And so these drugs were developed for patients that have these gatekeepers mutations that we cannot treat with vandetanib cabozantinib anymore. So the selective RET inhibitors, we have two. There's the salpercatinib or Retevmo and pralsetinib or Gavreto, and they're very highly selective for RET. So they inhibit almost only the RET receptor. We can see this here. So this is a table with the IC50s for these 4 drugs. So what does IC50 mean? It's the concentration in vitro needed to inhibit the growth of 50% of cancer cells. So the lower the IC50, the more potent is the drug against this specific mutation. So we see here for RET, cabozantinib and vandetanib have some inhibition, but we need way more cabo and vandi to inhibit RET compared to pralsetinib and salpercatinib. And on the other hand, cabo vandi have strong inhibition of VEGF, but pralsetinib and salpercatinib inhibited way less. And this is important because a lot of the side effects and the toxicity of vandi and cabo come from the VEGF inhibition because we're acting on the blood vessels. So this causes hypertension, risk of bleeding, etc. And so pralsetinib and salpercatinib have way less of these side effects because of this. And we see here that cabo vandi don't work against the 804 mutation, but pralsetinib and salpercatinib do. And so these drugs were studied more recently, and this is the study that led to the FDA approval of salpercatinib, showing great efficacy in both patients that were previously treated with vandi and cabo and those who had never been treated with any chemo for their MTC. And so this led to the FDA approval of this drug in 2020 for RET mutant MTC. And there's currently a trial that's ongoing that's comparing salpercatinib to cabo and vandi because, cabo vandi have been studied, salpercatinib, pralsetinib have been studied as well, but we don't have a head-to-head comparison to prove that salpercatinib, pralsetinib are really better. And so there's this trial that's happening all over the world that's comparing salpercatinib to these 2 drugs. And Lilly actually issued a press release a few weeks ago saying that the results they've done preliminary analyses, and these results show significant superiority of the salpercatinib compared to cabo and vandi, and these results should come up soon. So this is really confirming that these RET inhibitors are better. Now, pralsetinib also was studied in a similar fashion, showing, again, good tumor shrinkage with in both patients previously treated and those who were not previously treated. And again, this had led back then to FDA approval, but more recently, the company withdrew the FDA approval because they had to stay FDA approved, they had to do a similar phase 3 trial than what was done for pralsetinib. So compared their drug to cabo vandi, but the salpercatinib drug company beat them to it, did it way faster, and their drug is more used now. And so this company just said they can't do the same phase 3 trial. And so they withdrew their indication for MTC. So the pralsetinib is no longer FDA approved for RET mutant MTC, but for patients that are already on this drug, they're supposed to still have access to it and be able to continue it, but we can't start it for new patients. Other than their efficacy, what's good about these drugs, as I mentioned, is that they don't have a lot of side effects. I know that the list looks long, so it looks like they do, but the percentages, if you compare, side effects are way less frequent with the pralsetinib and the selpercatinib. Most frequent side effects that we see are hypertension and then increased liver enzymes and also decreased white blood cells. So again, these drugs are great, but they're not perfect and they still have some limitations. They still don't offer cure. Once you start these treatments, you still have to stay on them. And although they have less side effects, they still have some side effects. So again, not perfect. And we can also acquire resistance to these drugs. And we have learned to see that over the past few years as we started to see patients be on the selective RET inhibitors for longer. So how does the resistance to RET inhibitor happen? So again, we're blocking some of the RET mutations, the most frequent, like the 918, but we've come to see that by blocking these dominant RET mutations, there are new mutations that are emerging in the RET as well. And so here are listed the different mutations. I won't go into detail, but basically all of them are also going to impair drug binding. So the drug, the selpercatinib, the pralsetinib won't be able to bind to the RET receptor anymore. And so we have the 810 mutation, the 806, and the 738. And this is just an example to show you. So this is a patient that was treated with selpercatinib, patient with RET M918T mutated MTC. So this is before treatment with selpercatinib. This is the level of the M918 and the 804 mutation in the blood, quite high, which is expected because the patient has not yet received treatment. And up here are the CEA and calcitonin levels. So calcitonin was quite high, CEA as well. And then the patient was put on selpercatinib, and we have this great response. Calcitonin goes down, CEA goes down, and then the 918 and 804 mutation levels also go down. So the treatment is working, but eventually we see that here, calcitonin starts going back up, CEA as well. And when we look at the blood, we see that the 918 and 804 mutation levels are going up, so the initial mutations, but we also see various new mutations, and those are these resistance mutations I was mentioning, so the 806 and the 810. And so we're trying now to overcome these new mutations, and so to do that, they have developed some next generation RET inhibitors. So this was just to show you that the pralsetinib, selpercatinib don't work against these 810 and 806 mutations, but now we have new drugs, and I'll get to those in a second. Other than the new RET mutations, the tumor can also become resistant to selpercatinib or pralsetinib in other ways. So we can also acquire other mutations, not just in the RET. You can get a new RAS mutation or a new BRAF mutation that are also going to activate the MAP kinase pathway. So we're blocking here with our RET inhibitor, but the tumor is now mutated here. So even if we're blocking here, it's still going to get activated. And so the tumor outsmarted us, kind of. And then also the receptors here can be overactivated. And so this leads to overactivation and then tumor growth. So as I mentioned, to overcome these new RET mutations, they have developed second generation RET inhibitors. There are a few that are currently being studied. So these mutations work against the new discovered resistance 810. And most of them work against the 804, which we remember was the resistance mutations to Vandy and Cabo, but not all of them. So there's this one drug that doesn't work against the 804. And so this is the complete list of all of the trial. Some of them are actively recruiting, and others have stopped recruiting or are not recruiting anymore. And this is for patients that failed the selpercatinib, and now we need this new RET inhibitor. So this presents hope for patients that failed these RET inhibitors. So now I'm switching gears a little bit and talking about what we call the neoadjuvant approach. So we talked if you've failed therapy down the line, what can we do? But also some patients with RET mutant MTC present initially with big tumors that we can't really operate on, or if we do a surgery, we're going to leave some tumor behind because the tumor is very big and invasive, or even Sometimes the tumor is invading the food pipes of the esophagus or our windpipe, the trachea. And so if we do a surgery, we're going to have to cut a part of the trachea, maybe do a tracheostomy. So these are very morbid, invasive surgeries. And so we tried to think, how can we make these surgeries less morbid and offer better treatment? So we've been using the RET inhibitors. As we saw, they give great tumor shrinkage. So we've been using them before going to surgery. So the neoadjuvant approach is when we shrink the tumor and then go to surgery. And the idea is to make sure that we're getting a more complete surgery, taking the whole tumor out with clear margins, or making a tumor that was initially unresectable, now resectable. And so there's a trial currently ongoing at MD Anderson, as well as the University of Michigan, looking at neoadjuvant selpercatinib in patients with a RET mutant MTC. And so how we do these trials, this trial is that the patient's going to start on the drug, and then we treat them for up to 7 months with restaging every 3 months to look at how they're responding to therapy. And then if after 7 cycles, so 7 months, the tumor has shrunk enough for us to go to surgery, we do so, we resect the tumor. And then if the patient has no other disease outside of the neck, we can stop the selpercatinib. But if they have metastatic disease elsewhere, we can also continue it. And so we offer this treatment even for patients who have distant metastatic disease, because ultimately we think that a lot of the complications happen from the tumor itself. And so if you have a big bulky tumor, we want to try and get this one out, even if you have distant metastatic disease. And I just wanted to show you this example because I think a picture is worth 1,000 words. That's a patient of mine that I see at MD Anderson with Dr. Wagaspak. And so he presented to us with this bulky disease with huge lymph nodes in the neck. And so we put him on selpercatinib, and after only 3 months, we can see here that the tumors have shrunk significantly. And after 6 months of selpercatinib, there was also almost no tumor left. And so after that, the patient went for surgery, and now he's off of the selpercatinib and he's doing great. So this is really offering a lot of hope for patients that had initially inoperable tumors or that would require very, very morbid surgeries.
Even before thyroidectomy or just before the necklace?
No, before thyroidectomy as well. Yes, definitely. So now we're going to switch gear and talk about RAS mutant MTC. So we said about 60% of MTCs have a RET mutation, but then the second most frequent mutation is RAS. So unfortunately, as most of you probably know, for RAS mutated MTCs, we don't have specific targeted treatments like the RET inhibitors. We don't have that yet for RAS mutant MTCs. And so what we've been using is these anti-angiogenic drugs like cabozantinib and vandetanib, but we thought that they have a lot of limitations and they're very toxic, and that's what we want to try and improve in the future. So what they've been trying to develop in the lab is what we're calling pan-RAF or RAF dimer inhibitors. And so these RAF inhibitors, what they do is they're gonna come and inhibit here, BRAF and CRAF, and so they're gonna block down below the overactivated RAS, and so block the MAP kinase activation and hopefully block tumor growth and survival. And in vitro, it showed efficacy in all RET mutant thyroid cancers. And so now they're moving to phase 1 clinical trials in patients. And there are a lot of different clinical trials that are opening either in the next few months or in the next year with RAF inhibitors for thyroid cancer. And this is really, I think, a breakthrough for all RAS mutated thyroid cancers, MTCs and others, because we have not had any effective treatments for these tumors until now. And it's a good option for those who have a RAS as their driver mutation, so their initial mutation, but also we saw that you can acquire a RAS mutation and as a mechanism of resistance when you're already on another drug if you have a RET mutation. So this is also hope for these patients as well. So one of these trials is the SEACRAFT-1 trial studying this drug called naporafenib in combination with a MEK inhibitor, which is trametinib, which we also already use in other kinds of thyroid cancer. And it's in RAS Q61 mutant tumors, so including MTCs. It's what we call a basket trial. So it's any tumor with this mutation, thyroid or non-thyroid. They're putting all the patients together and studying this drug. So it's a trial based on the mutation and not the disease. And this is opening up soon at MD Anderson, but other centers as well. And this is the complete list of the other trials with RAF inhibitors that is going either are currently enrolling in the States. Sorry. So we've talked about different chemos and systemic therapies, but I just wanted to touch upon other potential therapies that we can think of in the future for medullary thyroid cancer. So the first thing I wanted to briefly talk about is what we call radiopharmaceuticals, or PRRT, which you might have heard about. So PRRT stands for peptide receptor radionuclide therapy. And so the idea of this, it's based on the fact that about 85% of MTCs express this receptor called the somatostatin receptor. Not all MTCs express it, but most of them. And in the same patient, there can be some heterogeneity, meaning that not all of the tumors in one same patient are going to express this receptor. But when you do express this receptor, then we can use this peptide that we combine with radioactivity. It's going to go link to the receptor and light up, and we can use that as an imaging modality. And you might have heard of octreoscans or dotatate PET CTs that we use to image MTCs that have this receptor. So here is an example. All of the black spots are the tumors lighting up, and so it's telling us that this patient has a tumor that expresses this receptor. And other than for imaging, we can also use this for treatment. So we combine the peptide with a different kind of radioactivity that instead of just lighting up, it emits particles that are going to kill the tumor. And so this is just another way of looking at it. So this is the radio-labeled somatostatin analog that goes to bind to the receptor. And depending on what we're putting in this, either it helps for imaging or it helps for treatment. Up until now, we don't have a lot of great results with PRRT, but it's something that can be studied more in the future. For now, we just have very small studies of a few patients, nothing that's very well done, but the studies that are available for now don't show great responses, and a meta-analysis including 98 patients, so kind of a summary of all the studies that are available, putting all patients together, showed only an overall response rate of 8.5%. So doesn't look like for now we have great results, but it's still something that could be studied more rigorously and that could still be kept in mind for some patients. So that's for PRRT. Now the other thing I wanted to talk about is immunotherapy or immune checkpoint inhibitors. So you might have heard about immunotherapy. It has been a major breakthrough in a lot of different cancers, but in thyroid cancer more recently, we've been starting to look at it and study it, and especially in MTC, it has not been studied a lot yet. So what are checkpoint inhibitors? So if we look at how the body responds to cancer infection, just a normal immune system, how it's supposed to work is that we have these cells, which are called antigen presenting cells. So these cells here, they're going to recognize that there's an infection or a foreign body or a tumor. They're going to go and show it to the T cells, which are kind of our soldiers that are supposed to attack and eliminate any infection or foreign body. And so they're going to go show it to them and activate them. And then the T cells are going to go and kill the cancer and the infection. However, if this happens too much, then the immune system is going to go crazy and the T cells might go and attack normal cells and not just the cancer. So the body is made in a way that this response is controlled. And it's controlled by what we call immune checkpoints. So there are two different checkpoints that are just going to keep the T cells in line and make sure that they don't go too crazy. And the cancer uses these checkpoints to its advantage to escape the immune response. So it's going to use these things to hide from the T cells. And so our T cells are not able to recognize and attack the cancer. So how does the cancer do that? The T cells are supposed to recognize the cancer using their PD-1 receptor on them like that. But the cancer is going to express something called PD-L1, and this is going to link to the PD-1 and impair the immune response. So the T cells cannot attack the cancer anymore. We have developed PD-1 and PD-L1 inhibitors to kind of counteract this. So PD-1 inhibitors, what they're going to do is they're going to protect the PD-1 that's on the T cell, and so the T cell is going to still be able to kill the cancer. And then the PD-L1 inhibitors, what they do is that they're going to kind of make the PD-L1 of the tumor not working anymore, and so the T cell can attack the cancer again. And then there's also this other checkpoint called CTLA-4. So the cancer uses it to stop T cells from killing the cancer, and by inhibiting this, so kind of hiding it from the cancer, the T cells can attack the immune system again. So basically what we're doing is that we're reactivating our own immune response, T cell response, to go and attack the cancer by using the PD-1, PD-L1, and CTLA-4 inhibitors. So in MTC, the reason why it has not been studied a lot yet, it's because MTCs are what we call cold tumors. So when we look at an MTC under the microscope, there aren't a lot of T cells in them. So it's not a tumor that elicits a lot of immune response. And so the idea is that there aren't a lot of T cells in these tumors, and so there's no point in reactivating them because they aren't really involved anyways. And so up until now, not a lot of interest about immunotherapy in MTC. We have very little data, some very small studies using immunotherapy that didn't show great responses. But now they're combining different kinds of immunotherapies together. There are 2 trials that are ongoing. But I'm still not sure that immunotherapy alone is the answer. But one way to look at things, and this has been used in other kinds of thyroid cancers, is to combine the immunotherapy with the kinase inhibitors like the cabo, the vandi, the selpercatinib. Maybe we can combine these 2 and attack the cancer from different ways. And this could be a future direction for treatment of more advanced or refractory medullary thyroid cancers. And the last thing I wanted to touch upon was CAR T, but I think you guys just came from a talk about the CAR T, so I won't go long about this. And I think you've heard that, we're not so encouraged about this in medullary thyroid cancer. But so I just wanted to rapidly explain what CAR T is. So again, the T cell is supposed to recognize the cancer and kill it, but the cancer hides from the T cell. It's protecting itself, and so T cells cannot recognize it anymore. And so CAR T, what it is that we're re-engineering the T cells so that they can be able to recognize the cancer again and attack it. And so we need to be able to have something on the tumor that the CAR T is going to be able to recognize. And the CAR T trial that's ongoing right now uses the GDNF family receptor, which is involved in activation of RET. And so this trial does not show great hope, but I think what we use for the CAR T can be different, and we can find new things to incorporate in the CAR T. And so I think that because that one trial is not showing great result doesn't mean that CAR T itself is not a great option. I think there's still place for research in that area. So in conclusion, I think that overall we've made a lot of progress in the past decade for the treatment of advanced MTCs. Vandi, cabo have only been FDA approved 2011, 2012, so it's been 10, 11 years that now we have options for patients that have distant metastatic disease, where before that we had no options almost. But it's clear that the treatments that we currently have limitations. They have toxicities, and even if they do work initially, a lot of patients are going to eventually progress because there's development of resistance, and none of these treatments offer cure, as I mentioned. But we're trying to overcome these limitations with different studies and trials that are happening. And I just mentioned the clinical trials, but obviously there's a lot of stuff that's happening in the lab, and people are studying different ways to overcome all of these limitations. And so I think that overall we can see that the future is bright for advanced medullary thyroid cancer, and there's a lot more to come, I think. Just before, I just wanted to, I don't know if you guys know about this, and I think my colleagues showed you this already, but I'll reiterate, if you haven't visited this website, it's really great. And if you have visited it and have feedback for us, please take the survey. It takes a few minutes and just allows us to make it better for you and for your loved ones. Do you have any questions, comments, concerns?
We have one question online already, so I'll just start with that one, and then we can open it up to the group.
Of course.
This person says, I've read that PFS is so long for one of these new RET inhibitors that they can't really calculate it and release it or specify it. Can you explain that?
I just wanted to go back to the actual slide with PFS to show you. But basically, when we're talking about a median, we're looking at the time it needed. So the median is when half of the patients have progressed. Basically, median progression-free survival is when half of patients have progressed. But let's say we've stopped the study after 5 years and half of the patients have not yet progressed, then we can't give a median progression-free survival. That's what we mean by not reach, or that we can't calculate it, because less than half of patients have progressed. And so that's why we can't give a median. And so it just means that a lot, after, let's say, 5 years, more than half of patients are still responding to therapy.
That's actually measuring the tumor.
The progression-free survival, yes, we do the resist, we measure, and then if the tumor is either stable or has not progressed. No, it's the actual tumor size, yes.
So if you develop a resistance to sulfatinib or whatever, and don't show one of these resistance mutations, do these other, you showed a list of other trials, are these other trials worth bothering with?
So if, let's say you have not developed a resistance mutation that is in the MAP kinase pathway, the RAF inhibitors, for example, would not be, worthwhile for you because this is not involved in your tumor's resistance mechanism. And so often, if we've started with sulfatinib because you have a RET mutation and you progress through that, then we often turn to our multi-kinase inhibitors like vandetanib or cabozantinib if we don't have anything specific to target.
How often should you be checking your mutations?
So usually we check it at progression. So if treatment is working and then at some point it stops working, then we want to try and understand why it stopped working, right? So usually at that time, what we're going to do is repeat either a biopsy or a test to determine what your mutations are. So either we biopsy the tumor that's growing. Let's say you have a liver metastasis that's significantly growing. We're going to biopsy that and look at the mutations under the microscope. Or we can also do a liquid biopsy, so a blood test looking at the tumor DNA in the blood.
Thank you for being here, first of all, and for the presentation. There's a patient, we'll call him a friend because he's a friend of ours in our online group that could not be here and didn't think he'd be able to be online. So he asked me to ask a question for him. He battled medullary years and years and years and kicked the can down the road long enough for Loxo to arrive on the scene. He's under the Loxo trial under the supervision of Dr. Worth at Mass Gen, and he believes he might be as early as patient 8 in the trial. So he's been on a long time.
Okay.
He has obtained a complete response. That complete response has lasted approximately 2 years plus. I wish I knew the exact time frame, but it's a lengthy period. Perfect labs, no scans show no tumors at all. His question is this: while a trial typically involves application of a drug, he's wondering if there is going to be a trial where patients like him with long-term complete response might be asked at some point if they would consider participating in a trial where they're removed from Retevmo to see what happens without the drug. Because we've all heard that once you're on it, you're always on it.
Right.
Somebody's got to be saying, but what if?
Yeah, that's an excellent question. And we're already starting to ask ourselves this in clinic, because before this was not even something we would ever think about because we had no good treatment that could offer this. But now we have these great treatments and some patients have these great responses and that are, long. And you talked about 2 years, we have patients 3, 4, 5 years, super stable, like no disease whatsoever. And so we start asking ourselves, should we try stopping the drug? So this is where we are right now. To my knowledge, there is no trial right now looking at that. And I don't think that it's a trial question, but in clinical practice, it's a question that we're starting to ask ourselves. And I think eventually we'll have to see how that goes. But yeah, that's a great question. And it's a question we ask ourselves every day when we see these patients with great responses, and it's just, you have to discuss with your patient and see what are the pros and cons. If he has no side effect, is going great on the drug, then why do we want to stop it, right? Yeah, but then could we stop it and just be off of chemo for 2, 3, 4 years? Maybe, who knows? The future will tell, but this is, a good problem to have though. Yeah.
All right. Any new trials for non-RET MTC?
Yeah, so all of the trials that I talk about for RAS, those are for non-RET MTCs. I don't know if there was another mutation particularly in mind, but
we have another question. Is there any role of sotorasib, I'm probably saying that wrong, for G12C mutated MTC?
Also, sotorasib, do we use that for MTC? I'm asking help from a friend. Yeah. Oh, sorry.
Hold on.
That's the KRAS drug that is approved for lung cancer. And we don't see a lot of that particular mutation. And I think I've maybe seen it once or twice in thyroid cancer. And so I've never used it in thyroid cancer, but it's something to consider for sure, especially for medullary, I think. does the person out there have that mutation?
Well, it's saying G12C, so I'm guessing it's a KRAS G12C. Looks like someone who knows their mutation specifically.
Yeah, so I mean, it's interesting because that drug is out there, and we collect the patients by their mutations, because if a drug comes out, right, then we're all interested. And actually, Dr. Cavanias was like, okay, we have to find, these patients, and I personally only had one patient with that, and it was a differentiated thyroid cancer, not a patient with medullary thyroid cancer, but the patient didn't need systemic therapy. But it's an interesting question, and if you on the Zoom have that and have disease, you might want to reach out to one of us. We'll tell you where the trial is.
Cool. Thank you.
So historically, you guys have not been all that enthusiastic about ablation for, obviously not for cure, but what's the current thinking on that? Is there any role for it, for example, for like debulking and symptom control? And if so, which type?
What ablation you're talking about? You mean like our radio frequency,
RFA
ethanol? Yeah.
Or cryoablation or ethanol ablation or whatever.
Yeah, we don't really use these approaches for cancers. We use them more for like benign nodules, biopsy proven benign nodules. For cancers, we don't have enough data to say that these work, for cancerous lesions. And I think if you have symptoms bad enough that you need debulking, then possibly either systemic therapy or surgery is a better option. I don't think that these ablative measures are efficient enough to get enough shrinkage if you have like compressive symptoms and you need a debulking.
In addition, it's like I'm on sulfatinib and my calcitonin is at 50,000. So I was thinking about it as like, could it help reduce the symptoms from them?
You mean the diarrhea? So if there's a lesion that's growing, for example, that's bigger, let's say a liver spot, a lung spot, we can often radiate those, or we can use some radioactive substance called yttrium-90 that we use for the liver mets. So I think you can debulk disease that way. But like ethanol and RFA for neck disease, I don't think that it has its place, or not yet anyways. For liver, it depends. It could be yttrium, radiation, depends from a case to another. Yeah.
We have a couple more questions online. One person asks, is it known if dosage of sulfatinib can affect how soon resistance occurs? And similar question for development of toxicity. Could there be a trade-off between dosage and development of resistance or toxicity?
Yeah, great question. So for toxicity, definitely, I think there's a relation between dose and side effects or toxicity. So if a patient has significant side effects on the full dose, we often decrease that dose. And the point is to find the right equilibrium between disease control, so the right dose that's going to keep the disease under control, but still give you a good quality of life and the minimum of toxicity. And so by decreasing the dose, definitely we're getting less side effects. For resistance mechanisms, I don't think that using a lower dose or a high dose is going to affect that, or not that I don't know of. I don't think there's data about that. But for side effects, definitely.
And another question, how many patients have you seen build up resistance to sulfatinib so far? And what have been their next steps? What stage are the second generation RET inhibitor trials in currently?
Yeah, so I don't have a number in head of how many we've seen, but when a patient progresses on a RET inhibitor, so up until very recently, we did not have the option of the second generation RET inhibitors, and so we would turn to Cabo and Bandy. But now we have some of these trials open at Anderson. So these are phase 1 trials. So they're at the beginning of their journey, but still, they're accessible to patients. So when a patient we're seeing in clinic progresses on a RET inhibitor, we refer them to the phase 1 team and try to get them on these trials. So they are accessible. And I encourage you to go on clinicaltrial.gov and try and see what trial is closer to you or open next to in a center close to where you are.
And one more online question, can sulfatinib cause sexual dysfunction and low libido for men?
Definitely, yes. And actually, I'm working with Dr. Hu in different centers in Europe to try and publish this. It's a side effect that's definitely underreported with the RET inhibitors. We're looking at sulfatinib precisely, but I think it's applicable to both. And definitely, we see more erectile dysfunction with sulfatinib. Yes.
All right. Well, thank you very much.
Thank you so much, guys.